Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep. And it's the veinclinicsofhawaii.com. Don't forget that little .com. We're going to refer you to the website often because that's where the action is. Vein Clinics of Hawaii on 4 islands, as you know by now. Started out on the Big Island and Osmose and got to the big city not too long ago. Dr. Randall Juliff is the medical director there. We've been talking about an awful lot of things. And one of the things that I found out, and by the way, not only do I host a show for Doc, but I'm also a patient. And one of the things I found out that every single one of us is somewhere on the chart of venous insufficiency of some kind. Maybe a little tiny thing like a spider vein, might be a big old horrible blood clot that you got to have surgically removed. But it is calming to know where you're in there. And today, Doc, you give me another chart, and I love charts and lists because I've always wanted to know, because I guess I'm a competitive person, where am I in the big picture on this chart? Where is Mike Buck in this deal? And isn't that one of the biggest things in your profession is to find out where a patient is with regards to how much of this disease do they have and how much suffering are they going through?
Where they are on the scale of severity. Yeah. But also, what is the reason? You know, there's a variety of different reasons why people might have vein disease, venous insufficiency, varicose veins, all that stuff. So when people come in, we have to define all of those things because it's going to impact how we approach them. You know, what are we going to do? How urgently are we going to do it? When do we intervene? When do we not intervene? Those are all very important questions as we're approaching each individual patient.
Okay, we have, gang, over the years that we do the show, tried to find out where you are on the chart, and there's actually in this particular field that I learned there's this range, 6 different places. And one's as different as day and night. And a little tiny one would be a spider leg on my knee, and a big one would be a huge, big hole in my leg that doesn't heal. Somewhere in the middle is where we are, right? And so so I was elated to find out where I was, only because it sort of explains things. And number one, when you're considering your options for treatment, you also find out from the doc, in your case, how severe it is, where this is, and how do we map out a treatment program that is going to make you not suffer or make you healthier, period.
Right.
And there you are, simple.
Yeah.
Not really, but we're saying it sounds simple.
Well, I think, we use a lot of these kind of, classification systems in all types of medicine.
Sure.
In the world of veins, we have something called the CEAP classification.
CEAP.
CEAP, right? Yeah. And the one that the part of that we use most often is the C part of it, and that you just alluded to that. It's C1 through 6. C1 being just spider veins, and nothing other than that. And at the other end of the spectrum, with a lot of space in between, but at the other end of the spectrum is somebody with a non-healing ulcer of the lower extremity, something that we call a venous stasis ulcer. So most people are somewhere in between. But the other, so we want a patient comes in, we want to know where they are on that clinical spectrum, because, that's going to certainly impact how we're going to approach that patient. But we also need to know those other aspects of the classification system that we use, the E, A, and P part of it. So E has to do with etiology, and so that means, why? Why do they have a problem? What is it about them that made them, develop the venous disease that they have at this moment, and have the clinical problem? So we're going to touch on that in a second, because we're going to talk about a patient here today that has an unusual cause for their venous insufficiency.
Okay, one thing that I've learned, gang, is a lot of this is inherited.
Yep.
And from what I understand, looking through the notes that I did, this guy was almost predetermined to be doomed into having some of this stuff.
Well, he was 100%.
Yeah. I'm just trying to be nice.
Yeah.
Thanks, Grandma. I mean, I appreciate it a lot, Mom. In my case, it was my mom. Thanks, Mom.
Yeah. Well, there's inherited, and then there's congenital.
Sure.
We'll touch on that in a second.
Okay.
But he had a congenital reason, and that's why I say so. It was in his genes that he was going to develop this process, and it's sort of an absolute thing. The only question is how bad is it going to be for a patient like this. But getting back to the other two parts of that classification system, the A and the P. A is anatomy, so that means which of the veins in our leg are having the problem. Is there disease? Is there non-function? We've talked about before, there are the deep veins and the superficial veins, and then each of those systems have different branches. And part of the classification system is to spell out which veins are affected. So that's
which, by the way, I found out, and the way they're divided, my friends, is really interesting, because some of them are so you can hardly even see them, and some of them are like big big pipes.
Yeah,
and they're all veins.
Right.
Yeah.
Sure. Yeah, all sizes. And then the P part of that is what's called the pathophysiology. Now that just means the physiologic abnormality that's happening. And basically it's one of two things. Either there's reflux, which we talk about a lot, venous reflux, and that has to do with valve failure. We've talked about that extensively, and blood going in the wrong direction. Excuse me. The other possibility is what we call obstructive, and there can be obstructive processes within the venous system that can lead to disease. For instance, DVT. If somebody develops a blood clot in their vein, then that's going to cause obstruction to flow. And even if they didn't have a valve problem before, that obstruction of flow up through the vein is going to very likely in the long term, create some vein functional problems.
Interestingly enough, gang, if you've been around the show before, you've heard this. It bears a little bit of repeating, and that is because this CEAP is and this chart, this clinical chart of 1 to 6, it's different for everybody, but people need to know that this isn't a disease like when you cut yourself with an axe when you're chopping wood. Now you have a big problem that needs to be fixed right away. Yep. This comes up and sneaks up on you.
Sure.
And all of the things that you've told me and that our listeners have learned over the years that we've been doing the show is that, everybody travels at a different speed, but this is the progression. And to get from one place to the other, you're not going to cure it, but you can sure slow it down. And isn't that sort of interesting? Because there's no guarantee that whatever treatment you get ever going to make the condition go away, because it's not likely to go away.
It's not likely to go away because of the genetic component
there you
of that.
Go.
Yeah.
Which this guy we're going to talk about. Right?
Yeah. Well, him as well as a lot of other people. But if we manage it appropriately, it should not be a health problem for that person, going through their life. But that goes back to that's the reason why we have to do adequate follow-up. After we even treat people, we still need to follow that patient over time, and often we encourage people to come back about every year for an ultrasound just to make sure that things are stable, make sure there's nothing new coming up. Because if they have that genetic influence that they have a propensity to develop vein issues, then they might. But hopefully, if we do adequate surveillance, it'll be kept to a minimum, and we can catch things early and intervene in a minimal sort of fashion, as opposed to doing, some, of the bigger procedures that we often have to do.
It seems to me that, of all the medical conditions you can talk about, things like asthma, high blood pressure, cancer, stroke, all of these different things, a lot of it is genetic. But it seems like in our case, or in the vein case, it's prevalent. I mean, that is the main reason, genetics.
Well, I have found that, for the most part, the inheritance factor is very, very strong. Yeah. Now, there are obviously lifestyle things that also impact it, for sure, pregnancies and people who work on their feet, all those things. So anyway, getting back to then the fourth category, the E part of that, we sort of skipped over that initially, but that's the E part of it stands for etiology, and that's getting to the why. Why does this patient have venous disease? And within the classification part of etiology, it can either be primary, secondary, or congenital. So primary venous insufficiency it has to do with, that's sort of the run-of-the-mill sort of version of venous insufficiency. Again, it's inherited. It's venous insufficiency in and of itself. It's not due to any other disease process. And most of these people just have, again, inherited the propensity to have that valve failure. Valves in the veins are failing. The blood is going in the wrong direction, creating what we call reflux, and that then leads to not only symptoms but problems with their legs as it goes on. So that's an inherited type of the disease process, but not really the specific genetic problems, which we're going to talk about in a second. The other subcategory within etiology is secondary. So secondary means that their venous insufficiency is due to some other process, like we mentioned before. DVT, blood clot formation in a vein, is ultimately going to have some impact on the function of that vein, and that would be a secondary form of venous insufficiency. Maybe that patient had trauma, or maybe they had some sort of surgical intervention, or other health-related intervention,
which is compounding the felony, right?
Yeah.
I mean, you got one thing going on here, and now something else. Then all of a sudden, now the two come together. It's almost urgent that you do something about it.
Sure. Yeah. Then the third option within the etiology category is congenital, and that's what we're going to talk about, a patient today with a congenital reason for their venous insufficiency. It's the least common. We see most of the patients that we see have a primary etiology. They have primary valve failure and related venous insufficiency. A smaller number have secondary. They've had blood clots or whatever, and that's the cause for the reason that they have then gone on to develop vein problems. The congenital part is, probably just a couple percentage points of the people, maybe not even that much.
Small percentage.
Yeah, it's a very small percent. And these people are people that are born with a genetic defect that is the cause or the reason for them developing ultimately their venous insufficiency. There's a good number of different forms of this, and they're all fairly specific. We're going to talk about one of them today, but again, it's not very common. But we always have to be thinking about this kind of stuff when we're evaluating people, even if we think it's just run-of-the-mill primary venous insufficiency. We always have to keep in the back of our minds, gee, is there some other process going on here that we have to be aware of?
Yeah, and on top of that, gang, I want to remind you that, there's any number of ways where you can get in touch with Dr. Juliff and his staff, but the easiest way is to check out the website. And this program is really sort of designed to make you aware of things that are going on and then pointing you at the website so that you can go take a look at it. Because the quicker you find out, when we go back to the CEAP the doc's talking about, the clinical part, the 1 to 6, is my goal is to make sure that everybody that listens finds out if they are on the chart, where are they? And what treatment is indicated to make you be able to live with this condition and always keep, stay, excuse the expression, step ahead of it. So you put your best leg forward, And so that's kind of neat to me, in that it seems like what you do is pretty organized. I mean, once you build a case file on me, then it's pretty, not only to indicate what's a treatment program, but what's the likelihood of me not getting any worse. Let's get a handle on this thing.
Well, it is indicative of prognosis. I think that's your last comment was getting at that. How well are we going to be able to treat it, and what's the likelihood of any particular patient having further problems in the future?
Sure.
How diligent do they have to be in keeping track of it, of maintaining surveillance, of continuing to do those conservative types of things that will benefit them over a long period of time, like wearing stockings that we talk about all the time. The classification system is such a beautiful thing because it lays all of that out for us. So anyway,
it's like when they explain on the Richter scale, or what sort of a tsunami is it, and you want to prevent that. The thing that I think is neat, and it's that, if anything, Doc, I think you and the other specialists like yourself are brutally honest because of experience. It is almost, you're not going to get surprised by too much of this. I mean, I know that there's new things happening all the time, but basically, once you identify where I am, you're going to help me determine where I'm going. That's all. That's all I want. It's all you can expect, really.
Right. And we try to be honest with people too, because again, it impacts. For them, it impacts how conscientious and how diligent they have to be in staving off further problems in the future, especially those people in those higher C classifications.
Yeah, and that's why I love it, gang, when we zero in and specifically bring up a particular case, because I do know that for every one of us that are out there, there may be 2 out of the 100 or 3 out of the 100 that are going to say, "That's me."
Yeah. Oh, yeah.
That
sure.
happens a lot, doesn't it?
Absolutely. Yeah. So the patient that I wanted to talk about today is a 48-year-old guy, and very active, otherwise very healthy. And he was actually he came into our Maui office a few months ago. And his presenting complaints were achiness, muscle cramping, burning in his feet and toes, restless leg, difficulty healing wounds, and marked swelling. So,
that's a lot of stuff on that plate. Yeah.
But a lot of symptoms, but all of them very typical of just general venous insufficiency. I mean, we see those types of complaints all the time. Because of the fact that he stated that he had some injuries to his leg that created little wounds here and there over the last several years that he found difficult to heal, that immediately kind of throws up some red flags. We're dealing with probably a little more advanced set of circumstances here that need immediate attention. But in addition to those symptoms, he also had very extensive varicose veins throughout his entire right leg, and a pretty substantial amount of swelling throughout his right leg. I think the hallmark kind of finding in this patient was that all of these symptoms were pretty advanced. All of the findings, the way that his leg looked on examination also were very, very advanced. But it was happening only to his right leg. His left leg looked perfectly normal.
Isn't that? I mean, it's not like me. I got both legs. I mean,
right. Well,
neither are really normal.
And most people are like that.
Yeah.
Most people with, again, garden variety venous insufficiency, usually they're going to have it in both legs. And it's surprisingly symmetrical, although it's not uncommon for one leg to be a little worse than the other. Typically, it's because one leg is a little further along in the timeline of the whole process. But it is unusual for one leg to be so bad and the other leg to be essentially completely normal looking.
And I'm so excited to find out the more about this guy, and I know that those of you listening are too. But the only question I have at this point, because looking at what his symptoms are and what he was putting up with, and at 48, had he sought treatment before?
No, he had not.
That's what I'm amazed at.
Yeah.
Look at how much this guy suffered for so long in little bits and starts, that had he had the ability to find out 10 years before his ability to enjoy. But anyway, the point is better late than never.
Yeah. So better late than never.
At 48, this guy comes in and you say, here's a guy. We got a lot that we can help him with.
Yeah. And especially in this patient in particular, had it been addressed, 20 years prior, which it could have been.
Yeah.
Of course, well, it's kind of a double-edged sword there because, I think that this type of problem we can deal with so much better now with the minimally
and your equipment and everything.
Invasive way, yeah. But had he been treated 10, 15 years ago when minimally invasive procedures were coming onto the scene, he probably would have benefited from that. But bottom line is better late than never.
Better late than never.
Sure.
By the way, gang, I'm so glad that this particular case history is a 48-year-old male, because a lot of times, until you learn on this program, venous insufficiency is an equal opportunity disease. Most people think it's all women, and the cosmetic part of it may be women because they tend to do it a little bit more than men. But this is certainly a good example of no. And even age, it's not 65 plus. This guy's only 48.
Right. Yeah, and as we'll find out here in a bit, he started with his at a very early age.
Sure.
So anyway, what do we have to consider when we're looking at somebody with what we call unilateral swelling? That, of course, means that, he's got symptoms and swelling on just one leg and not the other. So, the first thing we have to consider is there a deep vein process that might be going on that isn't immediately apparent to us? When we look at, legs, superficially, we can't tell what's going on in the deep venous system. Even when we do our initial ultrasound, we don't see, of the deep
It's amazing
veins
how deep
up
it
higher.
is, right? That's why they call it deep.
Yeah.
They're way in there, aren't they?
Yeah. So and there are also large, deep veins in the pelvis and in the abdomen that we can't visualize with the ultrasound. So we have to often do other things to make sure that there isn't anything going on there. Some of the other things that we have to consider was there a history of trauma or surgery? Did he get into a bad motorcycle accident 15 years ago, and did he have surgery for that? Is there a history of cancer and possibly surgical intervention for something along those lines? Did the patient have, radiation therapy? Radiation therapy can have an adverse effect on all types of blood vessels. Is there a history of that? Is there external compression on a vein, again, that might be higher in the body that we can't see and we don't necessarily visualize with ultrasound? So there's a number of different things that we have to consider when we're looking at somebody with swelling and symptoms in only one leg. Then there are other vascular type abnormalities. There's something called May-Thurner syndrome. We've talked about that before.
Wait a minute, I got to add that to my list. You say we talked about it before. My memory's not clicking in on that one. What's that?
Well, May-Thurner is a situation where an artery higher up in the body, in the pelvis.
An artery, not a vein. An artery.
Well, an artery is compressing the vein.
Oh, okay.
And can cause a fair amount of obstruction to that vein. And that's one of those obstructive reasons for somebody to have, vein disease. So we have to, that's one of the things that we think about when we're looking at somebody with swelling in one leg. Now, May-Thurner itself tends to affect the left leg more so than the right. This guy's right leg was swollen, so we're probably not really concerned about May-Thurner. But so anyway, those are all the things we have to consider. And usually there are other clues that, kind of help us hone in on what's going on with any one particular patient. In this guy, some of the other clues that we were presented with were the very, very early onset of his varicose veins. He started to have varicose veins in high school, mid-teenager years. Which is unusual, but is it unheard of to have just primary run-of-the-mill venous insufficiency in a young guy that age? No, it's not unheard of.
No.
We have a handful of patients, young men, 15, 16, 17, that have had pretty substantial varicose veins that we have treated. Again, it's unusual, but it's not unheard of. So.
Hey, by the way, I had one of these things a long time ago, and it was right around high school or college time. It was about as big around as a $50. Remember those things? We used to have things called $50. What happened to the 50-cent piece? Don't see them around anymore. Anyway, it's all quarters. Anyway, this is about as big as a $50. It's gone now. Can't ever tell it was there, but it was there for many, many years. And I learned from Dr. Juleff that the reason why that was there was that was one of the things that I inherited. And it really never manifested in any pain or any discomfort, but it certainly was something that I could see. And it showed us, didn't it, that there was things going on underneath there that needed treatment. And it was just sort of your body saying, hey, look at this. You got to go have this looked at because this is, quote, not normal.
Yeah, right. Yeah. It's a little sign.
So this guy put up with a lot of stuff. Did he understand, or did he explain, or did he think that some of it might have been from mom or dad or whatever? Did my whole family has leg issues or pain issues like this?
Well, in him it was a little different because he did not have a substantial family history of venous insufficiency.
Wow.
So, I'm glad you asked that question because that was another kind of clue to what was going on here. He didn't. So he probably didn't have. Again, run-of-the-mill primary venous insufficiency. And getting back to the young teenage boys that we have treated in the past that have had varicose veins, which, typically that's unusual. But those patients, those young men, typically had problems in both legs. Mm-hmm. And typically in a young person, either male or female, if they develop varicose veins at a very young age, like high school age, typically those people have a very, very strong family history of venous insufficiency. Probably both sides of their family, both mother and father have that genetic component. And again, this guy did not have any of that. So another thing was that at a pretty young age, again, probably high school age, he began noticing that his right leg was bigger than the left leg. So not only was it bigger, in girth, but it was also a little longer. Now, it wasn't long, to the extent.
These are things, by the way, that you keep track of and that you measure, because that's what we've been doing on my legs. Mm-hmm. So, and am I right to assume that sometimes the patients have no idea that one's bigger than the other? That's just my legs.
A lot of times they just kind of grow used to it and don't really put a lot of importance on it.
Until somebody says, "Hey, that leg's pretty big, isn't it?" Does that happen?
I'm sure it does. So as he got older, he noticed that continued, that pattern continued, where the right leg was bigger, and it wasn't only just swelling. It was the leg itself, the musculature, the soft tissue, the bony structure obviously was bigger if the leg was longer. So and then the other thing was that at a very young age, he noticed having a birthmark on the right leg. And then, when I was talking to him, I said, well, when you were young, did your mother say, you had that since birth and that kind of thing? And he did. So this was a dark purplish kind of,
thing,
discoloration on his leg that, typically people refer to as a birthmark. It didn't go away. It got a little bigger with time. Are
they ever dangerous?
They can be, yes.
Is that right? You get infected or something?
Well, not necessarily infection, but yeah, they're well in this scenario. It can. We'll talk about what happens in this scenario, but
I'm getting ahead of myself here.
Yeah, that birthmark basically is a vascular, what we call a vascular malformation. That birthmark, even though it looks like it's just a discolored area to the skin, it's actually an abnormality of the development of the blood vessel of whatever type, whether it's a vein or capillary or artery, whatever. But it's an abnormal development of the vasculature of the skin in the area beneath the skin. So it's something that we call a vascular malformation, and that was probably those were two of the big things with this patient that sort of were red flags for us. The fact that his venous insufficiency and vein problems were so early starting that one leg was bigger, and also this birthmark or this vascular malformation. As the years have gone by, his skin has gotten much more affected by the whole process. The skin is becoming thickened, it's becoming fibrotic, and also most notably painful. In the area of his leg that's most affected by all these changes, it's pretty tender. Even when you touch the skin and palpate his leg, there's a fair amount of pain that comes along with that. So, putting this all together, it started to sound a lot like something that we call Klippel-Trenaunay syndrome, which is one of those congenital reasons why somebody might have venous insufficiency. And so that was our, what we call our presumptive diagnosis, which means that, that was the diagnosis that we were going on, and we had to do, further kind of diagnostic studies to, figure it out completely. So, we did our usual ultrasound, and he had venous insufficiency, primarily superficial venous insufficiency, both the great saph and small saph. He had a little bit of deep venous reflux, but otherwise his deep venous system looked pretty normal. One of the things in these patients is that sometimes their deep venous system can also be fairly abnormal, so we're always concerned about that, and we need to define that completely. And then the other thing that we usually have to do in a patient like this that does not have a real straightforward reason for their venous disease and venous findings is that we have to rule out other forms of vascular malformations, and in him primarily something that we call an arteriovenous malformation, which is a malformation that involves both arteries and veins. It's something that we call a high flow kind of vascular malformation that has its own implications. But typically we have to do something to rule that out, not only in the legs, but also higher in the pelvis and in the abdomen. And typically we do, typically we'll do an what's called an MRA, an MRI of the vasculature or a CT scan. And we did that in him, and he did not, luckily, because there is a little more, negative prognosis for people with that form of the disease. So it looks like he has just kind of straightforward what we call Klippel-Trenaunay syndrome.
Let me ask you this. I think this is important because a lot of times if you break a leg, you go to the doctor, they take an x-ray, they see what the deal is, they set the leg, and out you go, and it heals. It seems to me that in your chosen field that there is a tremendous amount of investigative work and deduction and testing that goes on before you discover treatment. I mean, when somebody's got a broken leg, the treatment is put this puppy in a cast.
Right.
But it looks to me like this is something that I think that if you go to veinclinicsofhawaii.com, by the way, you'll see some of this. You really need to visit the website because that's what we want you to do after you listen to this program. But it seems to me that what you do is a whole lot of thinking and a whole lot of testing and sorting out stuff long before you do treatment.
That's true, and I think that's probably true in general with vascular kind of problems.
I'm not thinking, Doc, that other areas aren't important, but it doesn't seem to be that they are as demanding of investigation and thinking and theorying and testing as other things are, like vein surgery.
Yeah, no, you're right. You're right, Mike. I think vascular issues in general. The most of the diagnostic kind of things that we do define the problem pretty completely before we get to the point of treatment. And that was, that kind of occurred to me early on in my training because my initial training was in general surgery. And that's how, most people who get into eventually vascular and cardiac surgery, they go through general surgery training. So
yeah, I was going to say
we operated on the abdomen a lot, and people came in with pain or whatever symptoms. And we did an appropriate amount of testing, but we often didn't know exactly what was going on until we got to the operating room with these patients and opened their abdomen and looked around.
Wow.
And that's normal. I mean that's the nature of the beast. But in vascular surgery in general, we have a very, very good idea about what's going on before we get to the operating room, and the same goes for here. I mean, when I was doing heart surgery, we knew exactly what was going on with that patient's circulation of the heart. We knew exactly what we were going to do. And 99.9% of the time, we didn't vary from that.
I get you. Yeah.
And which is one of the reasons that I've been drawn to vascular surgery, because you know exactly what's going on and what you need to do. But the same applies to venous disease and the treatment of venous diseases. Yeah, we need to know what's going on. Because sometimes there may be things going on that if you take one course of action, it could make things worse.
Sure.
You don't want to do that. And, that is very, that idea is exemplified tremendously in a patient like this, as we'll see as we talk about it.
And let me also just alliterate for you all that the reason why this fascinates me, not only do I get to host a show with the doc every week, but I'm a patient of the doc's. I can tell you, though, that with all of the things that he's talking about, the reason why you must have been drawn to it, and others are that are in that field, it becomes, you really have to be a detective. You really have to be a researcher and a lot of other things, because, like you say, you don't want to do something that's going to make something worse.
Right.
And I do know that a lot of what you're doing there is so much more modern that anybody that's listening, that when grandma had her legs stripped, in the 1960s or 70s, it was like a totally different profession.
Oh, yeah, absolutely. And nowhere near amount of the diagnostic steps that we take today, were done back then.
Yeah, doesn't everybody have an ultrasound machine? Back in the day, if you'd have rolled that into your office 40 years ago, somebody said, "What the heck is that? Get that out of here."
Yeah.
I mean, that's some space cadet thing.
Yeah, absolutely. Yeah, I mean, just looking at ultrasound, I mean, that's a relatively new diagnostic device. And, back in the 60s and early 70s, we didn't have that, and there were all sorts of different things that we had to do and sometimes not even defining exactly what the problem was, but we were getting diagnostic tests that just kind of inferred, that this was the problem.
Now you can see it.
You just kind of have to go with it. Yeah. So what is Klippel-Trenaunay syndrome? So sometimes it's referred to as angio-osteohypertrophy.
Oh, jeez. I'm not even going to try to write that down. 3 times. And don't drink a beer and say that 3 times. It won't happen. Yeah.
And that basically just refers to the fact that there is a vascular problem, there is a muscular and soft tissue problem, and hypertrophy implies that there is enlargement of that extremity. But this was first described around the turn of the century right around 1900 by the two physicians that it's named after, two French guys named Klippel and Trelawney. I think the French pronunciation is a little different, but I don't know how to do that. So, Maurice Klippel. He lived from 1858 to 1942, and he was a fairly well-known French physician, as well as his partner Trelawney that helped define this. But they both, worked as physicians in Paris, and apparently had, a small number of patients that they found this same pattern of process going on, which basically it's the trio of things that we see are pronounced venous problems like varicose veins, enlargement of an extremity, and then also that birthmark, which is the vascular malformation, and we call that a port wine stain. That just has become the
that's what happens on a carpet when you spill a little of that port. Yeah.
Exactly. Because it's even more pronounced. These babies are born with these things, and it probably looks even more so on a baby as like a port wine stain, because it's kind of reddish purple, and on a baby it's very, very demarcated. But the frequency of this problem is again pretty uncommon. It's several, 1 to 3 people out of 100,000, live births are going to have, some form of this disease. So it's uncommon, but it's not unheard of. And one of the reasons that I wanted to talk about this is because it isn't unheard of. We had again this patient that came into our Maui office. We had another patient with similar kind of problems, also has the diagnosis of KTS, and that patient was in our Big Island office. So, that was just over the course of the last 6 to 8 months. So I'm sure there are plenty of people out there that maybe have not been diagnosed yet, so I like to talk about things that people can become aware of, and say, gee, yeah, that does sound like me, and maybe I need to have it looked into.
You know what I'm thinking of here in the background as you're explaining this?
Yeah.
Those two French guys sitting in their garage coming up with all this stuff. Because isn't it really, and this is why people get things named after them, that this becomes something that you use on a regular basis.
Yeah.
Thank goodness that they came together and said, hey, you know what? This doesn't look right. Let's think about this. And they came up with a whole new study.
Absolutely, and this is this happened around around 1900. So getting back to diagnosis. In 1900 we had none of that. We didn't even
120 years ago.
Yeah, we didn't have angiography or ultrasound or anything. So. It's pretty amazing when
they had leeches in a bottle.
Yeah.
Oh, brother. Oh my. Oh, yeah.
So anyway, this arises from a congenital defect, and when we say congenital, we mean a genetic thing that is present at birth. It's the genetics are not completely defined. However, there are genetic markers that will indicate whether a patient has this or not. But it has to do with a gene injury, an injury to specific genes at some point along the way. This happens obviously before birth, so it's either a mutation. There's some alteration of a gene or an injury to a gene or something called gene translocation, but there's, something, an abnormality of that specific patient's genetic code that arises, prior to birth and results in, this trio of things happening, which in some people can be extremely severe.
Were you able to, and once again going back to our patient, were you able to explain this? I mean, is this something that, as it became apparent to you what this guy's condition was, that it's something that he should probably know? And I'm wondering if there's a relief factor that kicks in when somebody says, "Geez, I don't know what Thank goodness you found this, because I had no clue."
Yeah, I think that was the case because the first time I saw this guy, I had the inclination that something like this was going on. And I talked to him about it. I said, yeah, unfortunately, you don't have a straightforward sort of thing. And I think, yeah, there is a little bit of relief there because he knows now what's going on. And we now can contend with it.
Sure,
We can make things as good as we possibly can. It's a, I think he was a little discouraged in that, the more I talked about it, the more it became apparent that this is not a straightforward thing, and it's something that he's probably going to have to deal with the rest of his life. Not probably, he is going to have to deal with this the rest of his life.
Same as me. And gang, there's another thing I want to tell you, and this comes up every now and again, and because of time, I mean, we have a lot of more things we're trying to cover today, but I want to tell you that unlike other conditions or other diseases, what Doc is doing is not searching for the right medication or the pill for you, because a lot of what you do is in your area of expertise, Doc, is surgery. I mean, there are certain things. There are no, here's a vein pill.
Yeah.
And I mean, maybe someday there will be, and I know there's probably guys sitting in their garages trying to come up with that stuff. But but in actual fact, what it takes is a trained physician to deal with this condition rather than a pill. Or a potion or a cream.
Well, it's with most venous disease, it's a mechanical problem. That's what it boils down to. And
so you need a mechanic. There you are.
Yeah.
You're my leg mechanic.
I'm just a plumber. But yeah, you need a mechanical remedy, and that's typically more than just a pill. Absolutely. So, anyways, so the vascular malformation that we've been talking about is something that we call a low flow vascular malformation, and low flow has to do with the fact of what this vascular malformation is made up of. And in Klippel-Trenaunay syndrome, typically it's a capillary kind of thing. So it's an overgrowth of capillaries. Capillaries are those very, very, very tiny blood vessels that kind of connect the arteries with the veins. Arteries bring blood, from the heart to our body, and when it gets to the end of the road, sort of thing, it releases oxygen, and after those red blood cells have released oxygen, they go through the capillary system, which is the tiny, tiny little, roadways that get the blood then back into the venous system, and so it can be transported back to the heart. So, we're talking about very, very tiny little capillaries, and when they become overgrown, more dense, and probably a little enlarged, that's then when we see that port wine stain. So, the in this situation, now there are other birthmarks that have to do with pigmentation of the skin,
right?
But that's not this. This is there's a vascular reason why we have that abnormal coloring of the skin.
What happens if somebody says, I've always been meaning to get rid of that thing. Let's take it off. It wouldn't seem to me that if you just took it away that it would really accomplish much. Other than appearance.
Probably yes.
Interesting.
Probably yes. And there have been, people have done that in this disease. They have tried to use, light therapy and that kind of thing to get rid of that vascular malformation to see if it would impact, long-term development, especially if you do it, when that individual is very, very young, and there hasn't been a good result from that, unfortunately. No. It's more, and that goes to the fact that it's more than just a cosmetic thing. There's a lot more going on here than just the the birthmark that they have. So it's a low flow vascular malformation, and this is as opposed to what we call a high flow vascular malformation. That's a vascular malformation that has to do with both an artery and a vein, something that we call a arteriovenous malformation, and that has a whole other set of implications. There is a form of this disease that involves a vascular malformation of that type, and again, it's harder to treat, and the prognosis is not quite as good. So
this guy got lucky.
Yeah. The silver lining here is that he's got just this. The port wine stain, capillary type malformation, and so hopefully we'll be able to treat him and control his symptoms over a long period of time. So, So we see the port wine stain, we see the enlargement of the extremity, and this is, again, it's not swelling. You know, the soft tissue and the bony structures and everything are enlarged, and that's why there's a greater girth to that leg as that patient gets older, and the leg is often a little longer in length. It can be variable. Some cases not present, other cases it's more severe. Sometimes most of the time it involves just one extremity. So the most likely or the most common scenario is it involves one leg.
One leg, yeah, which is what this guy was, exactly.
This is what this guy has. And however, it can involve more than just one leg. It can involve both legs. Excuse me. Sometimes it involves an arm. Sometimes it involves one side of the trunk or the other. So it can be pretty extensive. And again, I think the more fortunate people are those people that have just involvement of one extremity, and luckily we can do a fair amount to control their symptoms and findings in that one extremity. So the skin changes in addition to the port wine stain. Then the skin changes that we see are very similar to skin changes that we see in chronic venous insufficiency at those higher levels, those higher sea levels, that we've talked so much about. In chronic venous insufficiency, as that venous hypertension persists, and as we see the changes that occur in the skin, and that is pigmentation, darkening of the skin becomes thick and fibrotic and rough. All those things we see in chronic venous insufficiency, we also see in this situation. And we have to be concerned about the same thing, because these people also are very susceptible to skin breakdown, chronic venous ulceration, which we treat in a similar sort of fashion. It's just that that venous hypertension is a little more difficult to treat fully and control in people with this syndrome, KTS.
And by the way, if any of the stuff that you've heard about, it sounds a little bit like you, chances are it is a little bit more like you than you think. So what you really want to do, and I want to make sure before we run out of time, that we remind you that what you're going to do is you're going to go hunt online. You're going to have a good time looking at this at veinclinicsofhawaii.com. veinclinicsofhawaii.com. You'll see some of this stuff. And there's a way that you can contact the clinic through the website and get a consultation at no charge to find out if you indeed have some of these symptoms that need to be looked at and then eventually treated.
Yeah. They have getting back to what they have clinically, again, fairly extensive varicose veins. We've kind of talked about that, but I did want to touch on other organ systems that can go along with this also. And that's important because of the fact that, bleeding can become an issue. You talked about bleeding. You asked about bleeding before. KTS, the vascular malformation of Klippel-Trenaunay syndrome can be also internal, so it can affect the gastrointestinal tract,
which you don't see.
Which you can't see, exactly. So you can have those vascular malformations and hemangiomas in the spleen, and it often involves the lower colon and rectum, and the danger there is bleeding, because these vascular malformations are on the inner lining of the GI tract, and it can create either chronic blood loss or very sudden blood loss, which can be obviously a vascular emergency. It can involve the genitourinary tract, so you can have bleeding, blood in your urine, and this kind of thing can happen. So there are other organ systems that also have to be, sometimes evaluated and addressed. It's just various diagnostic things that we have to do to completely define that. and just do whatever has to be done with respect to those secondary kind of things. But the general treatment for this syndrome is similar to venous insufficiency, except that we go very slowly. We have to kind of do it in a very judicious and stepwise fashion, because it is one of those situations where if you don't handle it absolutely correctly, it can be, it can make things worse with time.
There you go. And gang, listen, we've run out of time, and we could go another couple of hours on this, and we will do some more on it in the future. But if you want to know more, the easiest way to do this is go to veinclinicsofhawaii.com, veinclinicsofhawaii.com. And, we want those legs to be healthy. You get those legs to be healthy, I mean, everything is just going to follow right in its footsteps and be just perfect for you. So please think about that, and think about Vein Clinics of Hawaii, and we'll see you next time. Aloha.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.